Hello, and welcome to the Fifth International Vatican Conference, hosted by the Vatican's Pontifical Council for Culture, the Cura Foundation, and STOQ, the Science and Faith Foundation. We hope you will join us in sharing the highlights through social media for these 3 days by citing @CuraFDN and the hashtags Unite to Prevent and Unite to Cure. Please note, if you are unable to attend a session, you can always view it afterwards on our platform on demand. Now please welcome our host, Dr. Robin Smith, President of the Cura Foundation and Vice President of the Vatican's Science and Faith Foundation, STOQ.
I'm Robin Smith, and on behalf of my co-trustees Steve Martin and Max Gomez, and our co-hosts Renato Paletti, Monsignor Trafni, and Cardinal Ravasi, we welcome you to the 5th International Vatican Conference on Health, Innovation, Medicine, Science, and Faith. The past year has affected every single human being in unimaginable ways. All of our lives have changed. The COVID crisis has forced us to close down entire economies, put entire countries on lockdown, stop travel, shut down millions of businesses, and has even affected our children's education in unprecedented ways. And sadly, we've lost over 3 million lives. Yet as devastating as this has been, when we look back on this pandemic, we will see a story of how the world came together to defeat an invisible enemy and avert even greater destruction and loss of more lives. While the battle isn't over yet, it's clear that we will win and be better prepared for what may come in our future. COVID-19 has brought the world together against a common adversary. People in science and medicine, business, government, and philanthropy have all embarked on a mission to save the world. Their response has been extraordinary, historic, and a lesson for the ages. The COVID vaccines were developed in just 1 year, a process that usually takes up to a decade. They pushed the boundaries of science without sacrificing safety, and the global response has produced benefits that can improve human health around the world. At the same time, the COVID pandemic also has exposed the harsh inequalities in medical care and the glaring social disparities in health. This crisis has given new urgency to addressing these gaps, and many of the leaders participating in this conference are focusing harder than ever on that goal. Combating COVID required a high level of collaboration across geographic boundaries and across a vast range of specialties that often operate in silos. This cross-disciplinary collaboration is clearly working, and it is this type of cooperation that will be required to tackle other issues in healthcare. It is also a hallmark of the International Vatican Conference. We seek to create a forum for discussion, collaboration, and taking action. We're so appreciative to our moderators who will be helping us navigate the conversations, and to all of our speakers for their participation. Even though, due to the COVID pandemic, we're not able to be together at the Vatican, we're forging forward online, inviting more people into the conversation and extending our reach even farther. Over the next few days in this virtual format, we'll bring together some of the world's foremost experts in their fields to share insights about the latest advances in health, how to make quality health care available and affordable, how to improve human health by addressing the mind, body, and soul, and how empathy and compassion can make the world a better place. We will also discuss the importance of preserving our environment, which affects the health of our neighbors, our families, and generations to come. Our heartfelt thanks to our collaborators, our grantors, our supporters, and our benefactors. They include Sanford Health, Cellularity, Akkad Holdings, the John Templeton Foundation, the Helmsley Charitable Trust, Sorrento Therapeutics, Aspire Capital, Hackensack Meridian Health, University of California, San Diego T. Denny Sanford Institute for Empathy and Compassion, United Therapeutics, Alliance Global Partners, Moderna, the Guthrie Jackson Foundation, AARP, the Eliza and Hugh Culverhouse Family Foundation, as well as Lawrence Krimker, John and Mary Papajohn, the Produce Marketing Association, Tivity Health, the Breton Family Fund, CRISPR Therapeutics, the Gary and Mary West Foundation, Healthy Villages, Horizon Blue Cross Blue Shield of New Jersey, JDRF, First Quality, Piper Sandler, Stern Aegis Ventures, The Church of Jesus Christ of Latter-day Saints, Cryoport, Dr. Randall Prost, the Susan Scott Foundation, Amicus Therapeutics, Arlene and Martin Bednar, Healthscape Advisors, Malik's Pizza Palace, Selective Benefits Group, and the Sovereign Order of Malta, and those donors who wish to stay anonymous. We are here today because of their generosity. We also appreciate your help extending the dialogue by using your social media channels to share the highlights of the conference under the hashtags Unite to Prevent and Unite to Cure. Please remember to tag us at CuraFDN on Twitter, Instagram, and LinkedIn, and also on Facebook at the Cura Foundation. I also want to thank His Eminence Cardinal Gianfranco Ravasi, President of the Pontifical Council for Culture, for his unwavering support since our first International Vatican Conference over a decade ago. He has been a catalyst for the powerful interface between science and faith, creating collaborations that can help us advance human health and preserve our humanity, our culture, and society. And now, please welcome His Eminence, Cardinal Ravasi.
Sulla soglia e in apertura di questo importante e imponente convegno, desidero rivolgere il mio saluto a nome del dicastero che presiedo. È il Ministero della Cultura del Vaticano, della Santa Sede, che ha come compito quello di entrare in dialogo con le culture contemporanee, con l'orizzonte nel quale noi ci troviamo. Questo saluto è rivolto in maniera particolare a tutti coloro che seguiranno in queste 3 giornate i più di 100 relatori che cercheranno in qualche modo di presentare da angolature diverse i temi che sono al centro di questo incontro. Con me salutano tutti, soprattutto gli studenti che parteciperanno e che ascolteranno questo itinerario, che seguiranno questo itinerario, con me la Fondazione STOC, il cui acronimo significa Science, Theology and Ontological Quest, cioè scienza, teologia e filosofia, che si incontrano tra di loro e cercano in qualche modo di scavare, di approfondire alcuni temi che sono fondamentali soprattutto per l'antropologia, che sono fondamentali cioè per il nostro essere ed esistere. Un saluto particolare va anche alla Cura Foundation, che è stata con noi l'artefice di questo evento in tutte le sue sfaccettature. A questo punto il viaggio dovrebbe iniziare. In realtà si tratta di un vero e proprio percorso che è iniziato molti anni fa. Questo infatti è il 5° convegno che viene sviluppato attorno a temi sempre diversi, però appartenenti sempre all'orizzonte della medicina, della salute, dell'etica, della filosofia e anche della teologia. La scelta dei temi è affidata a una sorta di triade. Sono un po' come 3 stelle che si accendono nel cielo, qualche volta oscuro, dobbiamo dire, della nostra contemporaneità, della modernità, e che toccano alcune componenti radicali, fondamentali della figura umana, della persona umana. Innanzitutto, come è facile intuire, una presenza fondamentale ha il corpo, la corporeità meglio, cioè questa struttura, questa componente che non è soltanto biologica o fisiologica, perché noi sappiamo bene che noi non abbiamo un corpo, noi siamo un corpo. Anche in questo momento, sia pure attraverso questa via a cui siamo stati costretti dalla pandemia, che è la via della comunicazione informatica online, ebbene anche in questo momento il corpo risulta decisivo Le mie labbra, i vostri occhi sono pur sempre fondamentali perché scocchi la scintilla del dialogo. Il corpo è quindi una realtà fondamentale dell'esistenza umana, della comunicazione umana. Ed è proprio anche nella sua fragilità che verrà studiata durante questi giorni attraverso voci qualche volta anche di altissimo profilo scientifico, ma anche attraverso la testimonianza di molte persone che si interessano di questa realtà da angolature, da prospettive diverse. Un grande poeta americano come Walt Whitman, nell'interno della sua opera più famosa, Foglie d'erba, queste poesie essenziali e fondamentali, ha definito il corpo come in assoluto la realtà più sacra che noi abbiamo. E questo può sembrare paradossale, ma non lo è nel cristianesimo, perché ad esempio nel cristianesimo il mistero centrale della fede cristiana, in tutte le sue denominazioni ed espressioni, è l'incarnazione, cioè il verbo, il logos, come dice il Vangelo di Giovanni, la divinità eterna, infinita, perfetta, diventa carne, e carne è appunto la corporeità, è la storia anche nella quale noi siamo immersi. La seconda categoria, la seconda stella che idealmente si accende in questo convegno è in parallelo, dovremmo dire subito, l'anima. L'anima che nella visione dell'antica classicità greco-romana era in opposizione al corpo. In realtà noi sappiamo bene che già quella stessa antica cultura greca aveva tentato di stabilire un collegamento attraverso un famoso filosofo Aristotele, così come il suo discepolo, il suo maestro aveva cercato di scindere questo legame tra corpo e anima. Questo grande filosofo Aristotele aveva cercato invece di stabilire un connubio, un intreccio, un abbraccio tra le due realtà. Ebbene, l'anima, noi sappiamo, è la coscienza, è l'identità personale, è l'autocoscienza, è anche la sorgente della tendenza al desiderio di essere verso l'eterno e l'infinito, verso l'oltre, cioè verso la trascendenza. Ed eccoci allora all'ultimo elemento, la mente che è quasi il ponte tra queste due realtà. Noi sappiamo che la mente non è solo, almeno nella visione che noi, culturale, che vogliamo sviluppare, non è soltanto il cervello, cioè la struttura neuronale straordinaria che è nell'interno della nostra scatola cranica, questi 80-100 miliardi di neuroni, che sono tante quante le stelle della Via Lattea, della nostra galassia, il che vuol dire cioè un vero e proprio microcosmo che è dentro di noi in questo spazio limitato. Ebbene, noi sappiamo che il cervello, il sistema neuronale, secondo una visione culturale e religiosa diffusa, non esaurisce le potenzialità spirituali, non riesce a descrivere totalmente la mente, che è qualcosa di più. E qui la discussione sarà complessa, ma certamente significativa, non per negare o per affermare soltanto qualche aspetto, l'uno o l'altro, ma cercare di integrarli e di metterli in dialogo tra di loro. Queste erano le 3 stelle di questo incontro, di questo convegno, a cui auguriamo un successo molto intenso, perché sarà un grande contributo soprattutto a quella categoria fondamentale che sta alla base di tutto questo evento e di tutti gli eventi che cerchiamo anche come Chiesa Cattolica ora di condurre sulla scia del messaggio di Papa Francesco, che alla fine lascerà anche lui la sua voce, entrerà anche lui con la sua presenza in questo convegno, cioè il dialogo, l'incontro di visioni che sono diverse, lo sentirete. Ci saranno delle voci tra loro distanti, ma tutte si incontreranno nel desiderio della ricerca. Perché, e concludo ricorrendo a due grandi culture, la cultura cristiana, la cultura biblica ebraico-cristiana, e alla cultura greca. La cultura classica ci diceva che una vita senza ricerca non merita di essere vissuta. Così Socrate, il grande maestro di Platone, il filosofo che abbiamo prima ricordato, e la Bibbia che ci dice che ecco in una preghiera, in un salmo, in un'invocazione, tu, o Signore, mi hai fatto veramente come un prodigio. La creatura umana è quasi come il più grande miracolo.
We are honored to have with us Dr. Anthony Fauci, the director of the National Institute of Allergy and Infectious Diseases. He sits down with CNN's award-winning chief medical correspondent and neurosurgeon, Dr. Sanjay Gupta.
For more than a year now, Dr. Anthony Fauci has been helping all of us here in the United States, around the world, get through this coronavirus pandemic. His steadfast approach, full of evidence and facts, has provided a sense of reassurance, but also helped us develop things like vaccines at unprecedented rates, which have obviously been helping countries all over the world. Dr. Anthony Fauci joins us now. Welcome, sir.
Thank you, Sanjay. Good to be with you.
You know, I want to ask you a question this morning that I'm not sure we've really talked about. And you and I have had many conversations. Sometimes, Dr. Fauci, science and faith can seem somewhat incompatible. Faith, you're believing in certain things, but with science, you want the evidence, you want the reason, the judgment. Just curious, how do you think about science and faith and the inflection points, but also when something is truly novel, as the case with this coronavirus, there isn't a lot of evidence. How much do you have to rely on just your own faith, not necessarily religious faith, but just your system of beliefs?
Well, I think you have to rely on it when you're starting with nothing, Sanjay, almost completely. And it's sort of an interesting dynamic process of as evidence accrues and you get more and more information, then you have that transition from what your instinct and judgment, you know, it's very interesting when you use the word faith, and I'm glad you said not necessarily religious faith. It really is a combination of instinct, good judgment, and calling back from experience. That, you know, in some respects is a non-religious faith issue, that as you get further and further and more solid scientific information becomes available, you pull away a bit from the kind of experience, instinct, and get more into what the reality of the evidence that you have. You know, and that's an interesting thing because it explains a lot about when we're going through a very difficult situation like the evolution of an outbreak, people who don't appreciate that evolution of understanding and evolution of knowledge, that you're going to change some of your viewpoints because the data itself will not necessarily change, but additional data changes the status of your knowledge. And your knowledge may go from minimal and you're acting on, quote, faith, as it were, versus the true substantive evidence and data, which really gives you a much greater foundation. So that's the way I look at it.
Yeah, I think it's really interesting. And I think when someone like you've been in this position for 40 years, you have a lot of pre-existing knowledge and you're going to instinctually, you know, just know things or be able to connect dots maybe in different ways just from that. That is what experience and judgment gives you. But how do you also allow yourself to be surprised, right? Because you're dealing with a virus, in this case, a novel coronavirus. But then some piece of data comes out that doesn't make sense. How willing are you to accept that sort of new data?
Well, that's a great question, Sanjay. And you must be flexible. I've said this so many times, flexible, open-minded, and humble to know that even though you have 40 years of experience, that when you're dealing with something that is really in the realm of the unknown, you've got to expect the unexpected. I mean, that's some of the dictums that I go by. Always expect the unexpected, particularly when you're dealing with a microorganism, which in many respects, from an evolutionary standpoint, has the capability to adapt itself to always survive. And organisms are not static things. And that's the reason why we're seeing the evolution of these variants. If it was a static situation, you would know exactly what it was right from the beginning, but it continues to evolve. I mean, I think one of the real good examples of that is that the dictum of infectious diseases forever were that respiratory-borne viruses tend to have a very small amount of transmission from an asymptomatic person. The thing that drives respiratory illnesses are fundamentally symptomatic people. And we know that influenza and other types of infections have a small fraction of maybe 24 hours before a person gets symptomatic that they can transmit it. We never would have imagined, and it was unique, that we were dealing with a virus where 1/3 to 40% of the people never get any symptoms, and 50 to 60% of the people who get infected from someone with no symptoms. That was completely unprecedented, totally. And that's the reason why when scientists were saying, it's not really a major driver, asymptomatic infection. And now you find out that it is at least half of the infections are transmitted. The reason why that's important, it impacts everything that you've been sort of like going by. It impacts the ability to do identification, isolation, contact tracing. It impacts the profound need to wear masks. When you say, well, I don't worry, if I don't feel sick, why should I wear a mask? Now we know that you could be spreading the virus. So that's what I mean by using your experience, using your knowledge, but always, always keep an open mind that you're going to find out data. They're going to have you change some of the things that may have been foundations of what you've done for years.
I'm curious, and I don't know how you would frame this, but if 100% is all of the knowledge that exists about a particular thing, in this case, the virus, where are we right now? I mean, how much do we know about this virus? How much do you think is still left to learn?
Oh, I think that there's a substantial amount, not only about the virus, what the virus can do, but the pathogenesis of the disease, the thing that, if I have the opportunity sometime to be able to slow down and get the lab to look at things, I want to find out, how could it possibly be that the same virus that's killed 570,000 people in this country is a virus in which more than half the people don't ever get any symptoms? I mean, you could say, well, they're young, they're healthy, but that's not an adequate explanation. There's something there, something that we don't know about the pathogenesis. The other thing that we don't know about is the ability, how extensive is the ability of this virus, if you don't really suppress it completely, to develop new variants. And every single week, Sanjay, that goes by, we get hit with another challenge. First it was the 614, first it was the Wuhan strain. Right. Then we said, wait a minute, we have a 614 now. Okay, so that's one variant. And then all of a sudden, the 351 in South Africa, and then the 117 in England, and now the 617 in India. It's like, it's a wily opponent. It's a wily opponent.
How worried should we be in the rest of the world about what's happening in India? Is that a cautionary tale?
Well, it's a cautionary tale from so many standpoints. I've seen this with HIV in a less dramatic way, where individual countries say it will never come here. We don't have the conditions for that to happen. You know, when India had that first blip and then it went back down, and then we saw doing the ceremonial feast at the Ganges River. When I saw that on TV, when you showed that a week or so ago, Sanjay, my heart sank. I said, oh my goodness, that is going to turn out to be something not good. And that's exactly what happened.
I'm curious, Dr. Fauci, in the minute or so we have remaining, going back to just this inflection point between science and faith. There's a lot of vaccine hesitancy in the world. We see around a quarter, 20 to 25% in the United States. To some extent, people need to believe, based on the evidence and the facts and the data, that this is a good thing to do, that it's going to help them, protect them and make them less likely to transmit the virus. What do you say to people right now, maybe even friends of yours, I don't know, who are vaccine hesitant?
Well, you've got to connect them with people they trust. The thing that we're finding out, that it depends, you have who is the audience and who is the messenger. You've got to match the messenger with the audience. And I think if you do that, you're going to overcome a lot of the hesitancy. When you go into the trenches and you have someone who's a deeply religious person who will listen to their clergy, that's different than me with a suit going into an area telling people to do something.
I think most people would listen to you, though, Dr. Fauci. I'm just putting it out there, and thank you very much for your time. One of my great aspirations, dreams, is that we get to spend some time together in person in the next several months. So hopefully we get to do that.
I not only hope, I'm going to make sure it happens.
Dr. Fauci, thank you for your time.
Thank you, Sanjay. Good to be with you.
You too.
Our conversation on shaping the future of healthcare for a healthier world features Dr. David Feinberg, head of Google Health, and Dr. Mark McClellan, who is both a business professor and director of the Duke Robert J. Margolis Center for Health Policy at Duke University. They are interviewed by Dr. Stephen Klasko, CEO of Jefferson Health.
I am thrilled to be here today. And I think one of the things that really makes this conference special is bringing stakeholders from all sorts of different industries together, and also that we don't mind asking the really tough and bold questions. And I think we've achieved both of those with this panel, with Dr. Mark McClellan and Dr. David Feinberg, bringing health policy, big tech, but all of us share the view that disruption needs to happen in a positive way. So I'm going to start with the most difficult question first, so the rest will be easy. So Mark, despite the ACA, CMS changes, some of which you've been responsible for, and David, despite the incredible amount of capital that's being invested in digital transformation, of which, David, you're working on very well with Google, so much of which, whether it be telehealth or online education, was not available to 20% of Philadelphians in my area who didn't have broadband. How do we move health policy, and those of you responsible for the fourth industrial revolution, to create an environment of, let's call it, universal connectivity, and be sure that we're not creating a new generation of virtually or technologically homeless group of underserved patients? How do we ensure that your zip code is not the most important component of healthcare outcomes? An easy question to start, and either one of you can go ahead.
Well, first of all, it's great to be here and to be with both of you. Let me push back, Steve. I think actually your zip code is the most important determinant of your health. So what's happening in your community is as important as your genetic code. And so access to food, understanding where housing is, understanding medical information in a way that makes sense to you is super important. So for us, it really is about organizing the world's information and making it useful and accessible. So when we think about things like COVID, for example, which I'm sure we'll get into, we have had 400 billion views of our COVID information page on YouTube. So that reaches wide audiences. The other thing that you mentioned around broadband, there's really the next billion users we think that are coming onto a mobile platform where smartphones will become much more common than they already are. And as those folks come on, what can we do to make sure that they can get the right information on their phones in a way that's mobile, that does what you're asking in your question and help equalize ability to access care, high quality care, and affordable care.
Just to pick up on David's comments, first of all, I too am really glad to be part of this unique dialogue. And zip code is a proxy for things that really matter for health, what your living conditions are like, what the risk factors in your environment are like, whether there's an easy place for you to exercise, and access to healthcare is a piece of that. Hopefully with the more detailed data and capabilities that are coming to act on that data for individuals, we'll be able to translate what looks like a hard thing to really transform a zip code into something completely different, into ways to make progress on that. There is increased attention driven by digital capabilities to be able to reach people where they are in their homes, as we saw happen during the pandemic, and to connect them to a broader range of resources to help improve their health. Not just scheduling a visit with a doctor, but figuring out if they're feeling isolated and mood issues or behavioral health needs could be met, figuring out if there are other social service needs, food insecurity, housing insecurity, and helping to connect that. Unfortunately, as you say, we don't have as much data connectivity as we'd like to support that. And I think one of the most important changes in healthcare that can help make that happen is to set up our payments or other policies in a way that reinforce caring for the individual where they are at home, and not just paying for services that are often downstream and not really going to get at those core issues that are embodied in your zip code.
Mark, let me follow up on that, because one of my mentors, Bill Kissick, when I was at Wharton, wrote a book called Medicine's Dilemmas, Infinite Needs, Finite Resources. Sound familiar? That was about 40 years ago. And he talked about the iron triangle of access, quality, and cost. And he said, if you increase one angle, you get increase and decrease another. If anybody says you're going to increase access, increase quality, and decrease cost, it's not going to be disruptive and painful and not telling the truth. So if you think about the ACA, there was a lot of, oh, good news, we're going to increase access, increase quality, decrease cost, it won't be painful. I think in our country, President Trump said, it's going to be terrific, fantastic, unbelievable, and huge, and it really wasn't any of those things. So how do we make sure that we're not just giving more people access? What can government do, not just giving more people access to a broken, fragmented, expensive, and inequitable system and hoping we'll transform? So you ran the CMS. What are the biggest obstacles to achieve that brass ring of sort of wider adoptions of all the things you're talking about, efficiencies and value-based care?
Well, one thing that is special in our time, as opposed to that, you're right, that iron triangle of cost, quality, and access has been around for a while. But one thing that we've seen consistently happen over the last 40 years, Democratic, Republican administrations, actually in the US and elsewhere around the world, is increased spending. And for a long time, for basically 1970, 1980 through the 2010 period, that was associated with improvements in outcomes, not just for wealthy individuals, but for lower income populations, Black and brown Americans, minority populations here and elsewhere in the world. That had started to change before the pandemic, where we're seeing a leveling off of improvements in cardiovascular mortality, an increase in so-called deaths of despair from substance abuse, violence, and suicide. And as a result, even before the pandemic, life expectancy in the US was falling. And with the pandemic, with a disproportionate impact on Black and brown Americans, we've seen a loss of the gains in life expectancy the last 2 decades for Black Americans, for example, and decreases in life expectancy overall. So we have more clear evidence now than ever before that it's not just a matter of putting more into healthcare that makes a difference. We need to put more into healthcare, like we were just talking about a minute ago, that meets people where they are, that uses digital technologies and other innovations like care teams and things that you're doing at Jefferson, Steve, to change the way that care is delivered. If we don't do that, if we don't sort of broaden the lens for care delivery to support digital health and these other innovations, I don't see those trends turning around.
Thanks, David. We've been friends and colleagues for a long time. You moved from the traditional healthcare ecosystem, doing a great job both in California and Pennsylvania. And now you're leading Google Health, and Google's transformed so much of our life. We spend almost $4 trillion a year in healthcare, most of it, as Mark said, for treating diseases and sick care, not necessarily preventing them. So and you mentioned before a lot about data, all the data you're aggregating. I've often said we don't have a problem of not having enough data. It's just we have a problem of what we do with that data. So how do you see AI and machine learning transitioning us to healthcare that's truly predictive, preventive, and outcome-based, which is what Mark talks about all the time in health policy?
Yeah, so let me give a couple examples, one kind of in the inpatient setting and one more from a community standpoint. So from the inpatient setting, our team in London came up with an app, really, really simple. So the rapid response team, the team in the hospital, gets called when a patient's starting to go into kidney failure. And the only thing the app did was tell you if creatinine went up, which is a measure of kidney function. Okay, that's it. Creatinine goes up. We saw a 30% less folks had cardiac arrest. Cost of care went down 14%, and time to diagnosis, 17%, and time to diagnosis goes from 4 hours to 14 minutes. Okay, so that's great. Then we say, well, instead of looking creatinine, let's do AI. So partnership with the VA, we look at 600,000 variables per patient in real time through their EHR. Now time to diagnosis goes from not 4 hours to 14 minutes, but -2 days. So 48 hours before anything happens clinically, we can tell you with 90% accuracy, this patient who has no clinical signs is going to be on dialysis. Like, it's fundamentally changing the sense of anticipatory medicine. So that's predictive. We can do the same with mammography. We can do the same when we look in the backs of folks' eyes for diabetic retinopathy. Not only can we reach specialty level performance, there's novel signals in there that none of us learned in med school. We can tell your hemoglobin A1C. We can tell your age by looking in the back of your eye. So that's in the medical side. But when we start talking on the consumer side or on the clinical side, folks come to Google when they have a new diagnosis, when they have a question, when they're trying to find where a vaccine is. We launched 5 self-assessment screeners, clinically validated tools that people can do themselves to see where they are. So examples are anxiety, PTSD, post-traumatic stress disorder, postpartum depression, COVID screener. The average person waits 9 years when they have an anxiety disorder like OCD before they share their symptoms with anybody, their primary care doctor, their spouse. I'm washing my hands so they bleed, but I have so much shame around it, I'm not going to tell anyone. Okay, now they can take a self-assessment, completely anonymous, on Google, see where they are, and then we can tee them up with teletherapy. We can help them find an FQHC. We can help them look at their insurance and see where they can get care, get an app, whatever it is. If we can take that 9 years down to 9 minutes or 9 seconds, we think that that platform that we have can really close the gap of people that are suffering to people getting into care. And we all know when you can get to the right level of care quickly, it decreases problems downstream, right? So if you can get easy access to primary care, or if you can get right into the urgent care, or you can do self-care, we know we avoid a lot of the trouble that comes when you make people wait, and then boom, in the night, something goes bad and they show up in the ER and our terrible system of do a lot starts.
So let's take that to the next step. Obviously, EMRs have been a big advance. Those are critical of the traditional EMRs, would say it's the first progress in technology in our history where you need more humans just to get back to where you were. We're hiring scribes just to get back to the doctor-patient relationship. How do you see Google working with traditional EMRs to improve these healthcare outcomes? And how do you see Google helping to potentiate and be part of that whole predictive analysis of data and interoperability sphere that we're clearly going to need, and something that Mark talks a lot about?
Hey, at Google, we're good at organizing information, right? That's a key thing that Google's good at. So we want to bring that technology into healthcare. So in partnership with Ascension, and we have other partners lined up, what we've done is say, look, the patient you're seeing has 3 or 4 electronic health records that are taken care of. They might be using something in the outpatient setting. They could be 1 or 2 different systems in the inpatient setting. We will normalize that information for you. And then we will present it to the doctor, the nurse, the clinician in a way that's totally intuitive. A Google search bar. So you get called in the middle of the night because you're the hospitalist on call, the patient has GI bleeding. You type into a Google search bar, anemia, melena, you can misspell it. And within a second, all of the information on that individual patient is now presented to you in a way that allows you to take care of them. Are they on any protein pump inhibitors? Are they, what are their normal hemoglobin levels? What are their vital signs? and then help you write the note, help you make sense of it. What we're measuring is, can we get doctors and nurses to spend more time with the patient than at the computer? And right now, all of us have had this experience where you go into the doctor and they say, what was the results of that test? And you know it's at the computer, and you look at them with disbelief. Well, one of the docs at Ascension said to us, I'll build a statue for you if you can find this person's CPAP, a measure of sleep apnea. And we said, well, just type in CPAP, and boom, it comes up from an OCR that was sent in from a fax. So we can take that information on an individual patient and allow that doctor or that nurse to find it in seconds. And that same normalization of data allows us to make predictions on populations, allows us to make predictions about who's going to be readmitted. The EHRs are fantastic because they digitize the record. Now what we need to do is put a layer on top of it that actually makes that useful. And it's useful for an individual, and we got to work on doctors' workflow. And it's also useful when you're managing larger populations.
All right, so Mark, David's got me really excited now that my dream of healthcare at any address, getting care out to where people are going to be potentiated by Google. But on the other hand, I think many years ago, Upton Sinclair said it's hard to get somebody to do something when their salary depends upon them not doing it. So what could an administration with courage do to start to align the payment models with value and outcomes in a way that would make both you and David happy?
Well, I do think the payment models matter. I want to get to that in a second. I also want to pick up on David's point about just how powerful getting the right data paired with the right AI tools can be for improving care. I do want to have a cautionary note there. So lots of data in EMRs. Most of it was designed, to your point, to support billing and delivering particular services when doctors are paid on the basis of delivering more services. So writing down all that detail is intended not just to help, and maybe not even namely to help the patient, but it's designed and organized to support payment. And great that we've got Google tools now that help make it actually useful for integrating data at the person level. There are some cautions there too. If you're not measuring the right data, you can make some big mistakes. There's a good study done last year and the year before by Ziad Obermeyer and some of his colleagues at Berkeley, which basically found that AI intended to help the most severely ill patients was actually aggravating racial disparities because the measure of severity that they were using was intensity of medical care use. So hospital visits, hospital spending, and that turned out to be more correlated with race and barriers to, structural barriers to access for African Americans than it was with actual health status. So you got to measure the right thing. And while EMRs historically have been good for care within the hospital, they often don't include basic information like, what are your living conditions at home? Do you have a safe environment? What zip code are you in? Things like that could really add value. So we got to focus on the data too. And to make all this run, exactly as you said, you'd like to have policies that make the right thing to do, the easy thing to do. So some of those policies include things like data interoperability rules so that people can have confidence that their data coming from different places that can be put together to get them the best care. It's going to be handled securely, and it's going to be handled in a way that's consistent with their wishes, and it's going to be handled reliably. But most important is probably the payment rules and shifting payments so that if what we really want is a usual source of care, a clinician or a team that's trusted by the patient and can help them make the most sense of putting together all of these different apps and tools that are out there that enable them to get more activated in making decisions about their care, more confident, more comfortable in dealing with issues like you said before, or like you all said before about some of the behavioral mental health issues, getting right connected to a telehealth service to assist them with that. That's not going to happen if we keep only paying for the complications and only paying for the stuff that happens in the hospital. So lots of promising work, and we've seen these models work during the pandemic for primary care groups or integrated care systems that are paid more on the person level, doing a much better job when fee-for-service revenues fell during the shelter in place and when new models of care care needed to be adopted that relied much more on telehealth, that supported things like getting a COVID test into a patient's home, getting that patient referred for therapy quickly if they became ill. None of that's well supported under fee-for-service. And so hopefully we've got a good tailwind coming out of the pandemic in the US and elsewhere to really move to payment models that support that kind of integrated person-focused care that David's tools can really help enable.
So let me take that. I mean, what I'm hearing a lot of is need for partnership. And in the book that Hemant Taneja and I wrote on healthcare, a manifesto for health assurance, we posited about what would happen if a Silicon Valley entrepreneur and the CEO of a 196-year-old academic medical system walked into a bar, got married, and had a kid. How would Google and a place like Jefferson or Duke, what would that kid look like where we're actually working together as opposed to just buying apps? David?
So I think we've had that kid. I've been at Google now 2+ years, and I don't come with a strong tech background, right? I come from the same background that you have, Steve, of running large health systems. After being here for 2 years, I am positive that our technology can save lives. It's mind-blowing. I'm also equally positive that if we don't get two things right, the technology will never make it to the light of day. And those two things are people have to trust us, right? We have to establish trust. And the best way for us to get that trust is through partnerships. So this isn't Google taking care of you. This is Google on an information page saying in the UK, this is what the NHS says, or in the US, this is what Mayo Clinic says, or your Ascension doctor saying to you, this tool is allowing me to take better care of you, or in our partnership with Mayo on radiotherapy for cancer patients. That's the Mayo doctor using our tool. We are not, if we're getting married, you and I, Steve, we are not the caregiver. We need to provide tools to those frontline people so they all have capes on.
Well, this is great. And I couldn't agree more that trust is more important than technology in some way. So I just want to end with this. I like to quote Jason Kidd when he went to the Dallas Mavericks, said, I'm going to turn this team around 360 degrees. We've done a lot of turning things around 360 degrees in healthcare, but just listening to you and watching what both Google have done, what you've done at Duke and CMS, I am really confident that post-COVID, we're not going to be using that quote 4 or 5 years from now. I can't thank you guys enough for being part of this amazing Vatican conference, and we'll look forward to hopefully next year at the Vatican.
Thank you.
We'd like to welcome the former FDA Commissioner, Dr. Scott Gottlieb, who will explore investing in better health and the power of preparedness with CNN's award-winning chief medical correspondent and neurosurgeon, Dr. Sanjay Gupta, and Dr. Albert Bourla, the chairman and CEO of Pfizer.
Hello, I'm Dr. Scott Gottlieb here at the International Vatican Conference. The global response to COVID-19 has been accelerated by extraordinary collaboration in data sharing, in research, and in epidemiological surveillance. Joining us here today to talk about how we can improve future response and build on a lot of the collaborations that have been forged in response to COVID-19, and what we can build on learning about preparedness for the future, on vaccine development, on distribution, on issues of surveillance, are Dr. Sanjay Gupta from CNN and Dr. Albert Bourla from Pfizer, where I have the pleasure of serving on the board of directors. It's great to be here with both of you. Albert, I wanted to start with you, if I can. In developing the vaccine that Pfizer pioneered this year, we saw new kinds of collaborations, not just in how vaccines were developed, but in how other therapeutics were advanced as well. Some of them very novel. Can you talk about some of those collaborations that you saw being forged this year, and how big of a role did it play in speeding up discovery and development of the vaccine and other therapeutics that I know Pfizer's working on?
Of course, Scott. And first, let me say what a great honor it is for me to be in the same panel with Sanjay and you. I think that in times of crisis, they say that characters are tested. I think also the cultures of corporations are tested. And I think that was a great test for the entire biotechnology, pharmaceutical, and regulators ecosystem. And I think all of us, thank God, we passed with flying colors. There were a lot of collaborations that had to be in place, and many of them were typical, and a lot of them were atypical in the way that we work. I would say that one of the most atypical collaboration is the one that we had ourselves with BioNTech. Not because we partner and we join forces to develop a vaccine. That's very common. We do that with a lot of therapeutics and vaccines, and this is how science is progressing, by joining forces. But we did that without having a contract. And I don't know if many people know that when we decided to join, I spoke with the CEO of BioNTech, my dear friend now, Ugur Sahin, and I told him, Ugur, understand that we are running against time. We will not have time for contracts before months. And he said, I understand that. Can we shake the hands through the Zoom camera? And this is how things went. We started, they shared their intellectual property. We shared our intellectual property with them. We placed billions into development. And the only thing that we were worried was, what is the next decision to make sure that the vaccine will be effective and safe? The vaccine had positive results in November 20. It was registered in December of 20. You know when we signed the commercial agreement? In January of 2021. Agreement that will gather billions of dollars were just put on hold just to make sure that we are all focusing on making the vaccine happen. I think these are the examples that I'm sure exist elsewhere in the industry that make all of us so proud.
Thanks for that, Albert. Sanjay, I want to put the same question to you, sort of in a broader sense. You sit across a lot of different venues. You see what's going on in the industry. What lessons do you think researchers have learned from the collaboration that's gone on in the context of COVID? And do you think we're going to be able to continue to collaborate with government, among private entities going forward? Have new models been forged?
Yeah, well, first of all, let me just say thank you as well for having me. And Scott, this is a real treat answering the questions from you. I've always enjoyed asking you the questions, so I appreciate this. And Albert, what an honor. Some of what you just described there is really fascinating. I've been covering this as a reporter for well over a year now, but you learn more about some of the background of this every day, it seems. Yeah, what I would say, Scott, to your question is that I think the public really had no idea, most of the public at least, how these collaborations work or how they come together at all, whether it's Pfizer and BioNTech or the NIH and Moderna, whatever it may be. People got a real sort of granular look at a lot of this. I mean, there's a lot that they still don't know, but I think it's very interesting for people. And as a result, the end product was something that I think is unquestionably being celebrated. The idea that these vaccines could be developed at this sort of speed and the pace of medical innovation has been forever accelerated, I think is something that people really talk about, they celebrate, they're enthusiastic about, and now I think they will come to expect, which I guess is part of the answer to your question. I think it will change because it's now been laid bare in a good way for people to see. So that I think is some form of that is probably here to stay. I think there's all these lessons going forward that people, everybody will sort of offer up in terms of what this means going forward, but I think it's here to stay.
Albert, can you talk a little bit about the mRNA platform, developing it, what you think it means for the future? Is it something that's going to be applied to other therapeutics, other vaccines? What does the future of R&D look like with mRNA?
I believe so. I think it's a technology that is maturing for the last 20 years. Ourselves are engaged with this one in the last 4 years. And we had to advance this technology, I think, by 10 years within one. That's the speed with which things were progressed. So right now we have reached a level that we understand so much about the nuances of this, that the field of applying it to therapeutics or other vaccines is wide open. I believe that we will see tremendous activity from multiple biotechnology companies right now, working on different type of vaccines and working on different type of therapeutics, like therapies for cancer or therapies for genetically driven diseases. And Pfizer, of course, is one of them. We are very, very eager and we have jumped already in multiple different applications of this technology.
Can I just add something as well? I had a chance to talk to Albert's dear friend Ugur Sahin and Özlem Türeci, his wife, who are the couple behind BioNTech, and a fascinating couple. Everyone should just read about them. Their honeymoon was going back to the lab right after they got married. That's the kind of couple they are. But so much of the work that they've been doing on mRNA, as Albert mentioned, was around cancer prior to this. There was some of their efforts towards vaccines, but so much of what Ugur was describing to me was around cancer. They hadn't quite gotten there yet, and then there was obviously a sudden pivot in January of last year. But the way that platform works, could work, I should say, I just found really intriguing. I mean, this is not my area of expertise, but when we talked for 2 hours about how these mRNA vaccines, or how these mRNA platforms, I should say, could induce an immune response for certain types of heterogeneous cancers. I mean, if we have the same sort of outcomes that we had with these vaccines, I just found that very, very inspiring.
Sanjay, you sit above the industry, you've followed this for a long time. Do you think that the work we've done in the context of COVID is going to help validate the platforms or help accelerate their potential use in other therapeutic areas?
I really do. I mean, I think that what has struck me the most here is, having been a medical journalist for 20 years, there was often a didactic nature to things. I think, based on 10 years of data, here's what, we're telling you. Here, what we saw was the world sort of learned a lot about this together. I didn't know anything about mRNA platforms prior to starting to report on it. I had to just learn a lot. Everyone did. And so I think that degree of collective learning, I think, is going to make people very interested in this, feel a little bit of ownership over this, brag that they can talk about this. I hear non-scientists describing this to their friends all the time. I love that. You do have a quarter of the country roughly that's hesitant for the vaccines, but I think the larger picture is they're hesitant about something that seems too new, or, okay, you told me it was going to take a long time. It took a short time. So that's got to be a concern, all those sorts of things. And I think that's got, everyone says this, but that's got to be addressed. Maybe the way to address it is really letting people in on the science. Here's it's just a little strand of genetic material. Here's what it does. It's a little Snapchat. It disappears in your body. Whatever it might be, to continue to hammer those points home will make a difference. It won't solve the problem, but I think it'll make a difference.
Albert, I wanted to come back to just the continued development work, and we're obviously seeing variants around the world that are raising concerns that we could have different phases of the pandemic if new variants become more common. How quickly do you think your labs, or labs generally, can be able to develop boosters to combat these variants? The one that we're seeing in South Africa, the one we're now seeing in India and elsewhere.
I think very fast, because we have right now already ongoing trials. As far as our vaccine, we have now data that the current vaccine works against the South African variant. Our study in South Africa had 100% efficacy. There was smaller sample, but 100% is 100%. Our real world data on the UK variant, which is the most dominant variant right now. And I hate that I call them with the name of the cities or the countries, but this is how most people know them. It was the most prevalent variant in Israel, and over the 85% of the cases were from the UK mutation, and we had 97% efficacy there. So everything we know it is that the current variants are covered by our vaccine, but nevertheless, we are trying the efficacy of a booster shot, and we are trying the efficacy of a booster shot of the same vaccine against the wild type and all the variants, and also the efficacy of a new vaccine, which is tailor-made for the South African variant against again the variants and the wild type. And this data will come in 1 month or two, so it's really imminent. And right now, I think what is the important, it is that we know that the possibility that the variant that will escape, that will evade the protection of the vaccine is real. So that can come anytime. So as a result, what is important, it is that you have a system, that you survey all variants, and that you have readiness, that you will be able to develop, if needed, a booster vaccine in very short period of time. And right now, I'm happy to say that we have our process is geared to do that in less than 100 days. Right now, we are already 90-something days that we should be able, from the day we make the decision that this is a variant that we need to do something about it, within 90-something days, to be able to have a product ready.
I should just comment, Albert, you've been outstanding at keeping the board of directors, including myself, informed through this crisis on Pfizer's ongoing work. So I am putting you in the unfair position of asking you questions to elicit information I already know, but I want the audience to know. So I thank you for playing along.
Can I ask something that I don't know, because you both know all this stuff so well, but the boosters that you're talking about, especially the ones that are variant specific, do they have to be reauthorized, or how would that be handled from a regulatory standpoint?
Yes, they have to be reauthorized. I think that should be a very different process than a whole new registration, but we have a ton of expertise because, or there is already established regulatory pathways because of flu. In flu, you have a registered vaccine, and then every year you need to change the strain. And there is a process what you need to do so that regulators around the world will approve it or not. But you have the best regulatory expert next to you. I think that comes to Scott.
Yeah, in the context of flu, Sanjay, you're looking at the immunogenicity induced by the vaccine against sera. You're not even looking serum. You're not even looking at clinical data. So you're looking at how the vaccines are able to produce antibodies that target the specific epitope that you're trying to enlist a response against. And so in the context of coronavirus, I think what you're going to see emerge, and it's going to evolve over time, but I think what you're going to see emerge is the ability to authorize new vaccines on the basis of immunogenicity data, the ability to demonstrate that you can develop antibodies that bind to the new epitope, so the particular spike protein that's in 1351 or B117, without looking at outcome studies. The FDA will rely on the original finding of safety and effectiveness from the original studies on the overall vaccine construct, and just be looking at the ability to generate specific antibodies to specific epitopes with some of these new variant vaccines. I think that that's the construct that they'll come up with. So they'll probably still require some clinical data to look at antibody response in people, but they won't be looking for long-term outcomes in those studies.
So go fast.
And if I can add here, one of the reasons why, for example, I was convinced let's go with the mRNA technology was because of how flexible this technology is, to be able to adapt to changes and to adapt your vaccine to changes of the variant. One aspect is manufacturing, for example. Right now, we have a process that we will lose not a single dose. So the machine or the whole process will produce the current one, and then very quickly, without any delays to adjust, we'll start producing the new one. And we will just replace the current doses with the new ones. This is not the case with all the technologies that you need to start and go through the whole new process. And so it's very, very dynamic, and it is really tailor-made for something like that.
Yeah, and Sanjay, you'll remember in the swine flu in 2009, one of the rate-limiting steps, one of the reasons why the vaccines were delayed, the flu vaccines that we developed that season, was because there was difficulty getting that new strain to grow in cell cultures, and the yield ended up being much lower than what the companies were anticipating. So, the rate limiting step in the past has been the ability to culture the virus and get it to grow in cell culture in the yields that you need to provide a sufficient amount of vaccine. Here, it's, Albert's described it to me as sort of plug and play. If you come up with a different mRNA construct, you can basically put it into the existing manufacturing processes and have a reasonable degree of assuredness that you're going to get the same yields and the same output. Did I say that right, Albert?
You said very well. Actually, I asked our head of manufacturing, so how much are we going to make? At least 2.5 billion doses this year. If we have to switch mid-year to the new vaccine, how many doses are we going to make? 2.5 billion doses. It's going to be just plug and play.
Sanjay, I want to get you back into the mode of being someone who answers questions and doesn't ask them. So I'm going to put a question.
Can't help myself.
yeah, you can. You can't control.
You can't help yourself, Sanjay.
You've covered a lot of emergencies, a lot of epidemics in the past, disasters over 2 decades. You've been doing this. How does this sort of fit into that picture? I mean, obviously, it's got to rank up at the top in terms of severity. How do you compare it to what you've seen in the past?
This was far and away the most intense from a coverage standpoint that I think I've ever had, and I think there's a few reasons for that. One is that, you know, obviously, really since, you know, January, maybe even late December, because we were sort of monitoring what was happening in China in December of 19. We've been at this. I mean, all of us have, obviously. So, but you know, it's just been just relentless, really, in terms of the coverage. And I think what journalists often do is I wake up very early, you know, before 5 o'clock in the morning every day, so I can talk to some folks on the other side of the planet who may be ending their day, and, you know, really just trying to learn as much as I can about something that was so novel, despite the fact that I've covered outbreaks and epidemics before, and even a pandemic like H1N1. This just was different. I think on a more personal note, nature of a pandemic is, I guess, no one is really insulated from this, you know, and so I'm dealing with I have 3 girls, age 12 to 15. By the way, I do want to know when they can get vaccinated. I'll ask that later. But 3 girls, and, you know, we decided to keep them home from school for a while, you know, worried about what was happening and just navigating all the realities of life through this. I think when you cover conflicts or natural disasters like Haiti or Pakistan or Japan, it can be intense, but you know you're coming home at some point, and I'm going to sleep in my bed, and it's going to be a different world. Here, we were all just very immersed in it. I liken it more, I think, Scott, you'll appreciate, to chief year of residency in some way. My chief year of residency, all I wanted to talk about and learn about was the brain and the spinal cord. That's it. I really didn't have a lot of time or interest in being social or talking about other things. It's kind of been that this year as well. My conversations are about this virus and all the work that you guys are doing. I've not been very social, I think, probably like you guys as well. So that's been very different personally and professionally.
Well, thanks for that. Thanks for your time today, Albert. Thanks, Sanjay. It's been a pleasure to join with both of you today. Thanks a lot.
An honor. Thank you.
An honor. Thank you.
Religious leaders, Rabbi Dr. Eli Abadi, Cardinal Gianfranco Ravazzi, Elder Dr. Dale Renland, and Sheikh Dr. Asim Youssef will now discuss religion and the pandemic.
L'esperienza della pandemia, come le esperienze delle catastrofi naturali, di loro natura pongono alla persona umana, a chi riflette, almeno 2 domande. La prima domanda, che è stata tante volte usata per semplificare il discorso, è quella classica che è anche nel titolo di uno dei romanzi più famosi dell'umanità, probabilmente, Delitto e castigo di Dostoevsky. Se c'è questa punizione, questa sofferenza, è segno che in qualche modo c'è una colpa, ci deve essere una colpa. E allora qui si va a cercare anche una colpa sociale, per esempio non aver rispettato alcune norme di convivenza per la pandemia precedentemente, non aver rispettato certi stili di vita porta alla fine a questa conseguenza. E l'altra interpretazione è questa: noi siamo immersi in una realtà che è finita, caduca, mortale, creaturale, il limite della persona umana, il limite della natura. Che esistano delle catastrofi naturali è legata al fatto che la struttura della materia stessa è una struttura che ha al suo interno non un percorso lineare, ma dei percorsi con delle cadute. La stessa cosa vale per la persona umana stessa, per il nostro corpo che è limitato, caduco e che quindi ha al suo interno anche, per esempio, il fenomeno dei virus. Il male è costitutivo, il male fisico, psichico anche. Pensiamo per esempio alla violenza, alla mancanza etica. Esistono delle componenti che noi non riusciamo a controllare e dobbiamo dire che nell'interno della pandemia si è visto che c'è certamente la responsabilità anche umana, ma alla fine anche c'è qualcosa che ci supera, che noi non riusciamo a comprendere perché per esempio quella persona sì, quell'altra no, perché il meccanismo delle realtà umane, delle sofferenze sia così eterogeneo. E su questo la cultura, la filosofia, la teologia da secoli si interroga senza avere una risposta definitiva.
I know there have been plenty of religious functionaries in every religion trying to give their explanation as to why God sends corona. We ought first to address it scientifically and how we could fight it and protect ourselves. Then we could sit and decide religiously or philosophically as the reason.
I think when we worry and focus on things that we can do instead of things that we can't do, we feel more optimistic about our circumstances. We can wear masks to help others. We can wash our hands. We can avoid touching our face. We can avoid coughing or sneezing without covering our mouth and nose. Those are things that we can do, and we can try to do the best we can within the circumstances we're given.
And it is absolutely a responsibility of faith communities to examine themselves, examine their influence that they wield, whether at a level of organization, institution, or at the level of individual members of their community, and seek to infuse those more operational aspects of human society with those very same divine qualities of mercy, of kindness, of generosity, of compassion. And those wealthy countries now have far too many vaccines than they will ever need. So what do you do about this? And yes, there are systems in place, but faith communities have a responsibility here to lobby those who are in power to be generous, to view all human beings as one where this is concerned, to not think about national barriers or cultural barriers, but to bring this benefit to all mankind, to all human beings. And to understand ultimately that we are from one soul,